and good afternoon, everyone. Am I audible? So I hope I'm audible. Good afternoon, everyone. Thank you so much for joining this webinar session on myositis. And meanwhile, we let the people join. Uh, I just wanted to brief about why this webinar has been kept today. So I think today is World Myositis Day, September 21st. And myositis, as we know, it's an autoimmune disease. And for the clinical management and the diagnostic solution, we've kept this webinar just to understand how the clinical management and the diagnostic management works hand to hand. As we all know, the clinical aspect and the diagnostic aspect works hand to hand, and in every aspect, in every management of the disease, we require those both the aspects, and for the welfare of the patients and for the welfare of betterment of the patients. So I think without taking much time, I would like to introduce our senior panel members here. So we have Dr. Ranjan Gupta. So Dr. Ranjan Gupta is an MD DM at Clinical Immunology, and he is an esteemed additional professor in the Department of Rheumatology at AIIMS, New Delhi. He is recognized for his contribution to clinical immunology and rheumatology. Dr. Gupta represents India as an ambassador for the Eplar Young Rheumatologist, a prestigious platform dedicated to advancing rheumatology in Asia and Pacific region. He also serves as a member of IUIS Auto Antibody Standardization Committee, contributing to the global standardization of autoimmune diagnostics. Additionally, Dr. Gupta holds a key position as an executive committee member of the Indian Rheumatology Association for 2023-2025 term, where he is actively working on the future of rheumatology in India. So welcome, Dr. Ranjan Gupta, sir. So we welcome you on the
Thank you very
behalf of
much.
Dr. Bilal Clinical Laboratory. So we just wanted to know, so what is your expectation from this webinar, and what are the key takeaways that the audience would take at the end of this session of myositis clinical management through diagnostic solutions?
Yeah, thank you first of all for such a nice introduction. So my focus would be on clinical aspects of inflammatory myositis. I would be giving the clinical pictures and the scenarios, clinical scenarios by which we help to differentiate patients of myositis into one of the categories, which is required for making, not just making the diagnosis, but also in their management.
All right. So thank you, Dr. Ranjan Gupta, sir. And I hope, I am definitely sure the attendees who are attending this webinar would take away a lot of things, and it would be an insightful webinar session for them also. Taking Not taking much of the time, I would also like to introduce our second panel member. She is Dr. Monika Agrawal, and she's currently working as a senior consultant and director of Center of Excellence Autoimmunity at DrBLalLab Clinical Laboratory. She has an 18 plus years of experience in bacteriology and mycobacteriology and mycology, serology, ELISA, and infectious diseases. She has more than 15 years of experience in autoimmunity. She has handled more than 20,000 IFA cases and hospital infection control. She has an expertise in HPLC, protein electrophoresis, maternal screening, and clinical biochemistry. And talking about her areas of interest, those are autoimmunity, hospital infection control, and AMR. She has also worked in a lot of renowned hospitals all over India, like Saket City, Nova, Ortho, and Spinal Surgery, Apollo Cradle, Jeevan Mala Hospital in Delhi, and Patel Hospital, Jalandhar. She has also published many articles in international and national journals of repute. So I would like to welcome Dr. Monika Agrawal on the behalf of Dr. Bilal Clinical Laboratory. So, ma'am, thank you so much for joining this session. And also, we would like to know what are the kind of expectation that you are having with this webinar, and what are the takeaways that people are going to take from the diagnostic point of view in managing autoimmunity.
Thank you so much, Nikunj, for giving me opportunity to talk about the most important topic nowadays, post-COVID, actually, because autoimmune disorders are the, I think, most neglected diseases now, which usually people does not even think about, because most of the diagnosis, they go towards infectious causes. Most of the time, they go for the infectious causes not for the autoimmune causes. It comes at the end of any diagnostic algorithm. If we go for that. So today I'm basically going to talk about the what are the different diagnostic modalities we have, and definitely Dr. Ranjan will enlighten us for the clinical as well as the management part of the different kinds of myositis. And it is, I think this webinar is going to help our listeners. Specifically, we are basically combining all the three modalities under one roof, and it is going to benefit each and every person in that.
Thank you so much, ma'am. And I would just like to confirm with all the audience here, everyone has the access to type the questions and answers in the Q&A section here. And I would just like to know, is our video visible? Is our audio audible for you, all of you guys? If you can just share a thumbs up or a yes on the chat option. You have a Q&A section down at the footer section. You can just type yes or no. Okay, so we have received some answers like yes. Okay, so we are audible and we are visible. And I think without taking much of the time, I think we'll have to take this session forward. So I would like to welcome Dr. Ranjan Gupta, and I think Dr. Ranjan would be taking the first half of the session, and then Dr. Monika Agrawal, and then we would be taking some question and answers. Even we can let some people speak and ask the questions to the panelists. So whenever it is possible, you can just raise a hand. We'll allow them to speak. And let's take it forward. Dr. Ranjan, over to you.
Thank you, Mr. Nikunj. I'll just share my presentation here. Yeah, so I hope my screen is
Yeah.
visible.
Yeah, exactly.
Okay. Yeah. So the topic for my presentation would be the inflammatory myositis, their clinical presentations and clinical management. So we all know that inflammatory myositis is a group of autoimmune disorders, which are also known as by various names like idiopathic inflammatory myositis or even autoimmune myositis. Now, this is a heterogeneous group of autoimmune disorders. So what do we mean by that? That there are diseases within this group which have got different manifestations. So they are not all alike. And you can't employ the same treatment, same diagnostic criteria, same measurement, same antibodies to all the diseases within this group. They all have a thing in common. They have a skeletal muscle involvement in the form of myositis, which causes muscle weakness, which is definitely more as compared to other organ systems in the body. And that is how they have been put into this common basket called inflammatory myositis. Now, based on their clinical, serological, and histopathological features, they have been divided into 6 subtypes. These are broad subtypes. Some of them have actually been discarded nowadays, but mainly we can classify them into 6 types, and these are known as dermatomyositis. We have anti-synthetase syndrome. We have immune-mediated necrotizing myopathy. Other one is inclusion body myositis. And then we have a smaller group, polymyositis, and then the overlap myositis. So coming to their basic manifestations, if I say, the things have changed as to what it was 10, 15 years back. That time, the muscle enzymes, the clinical presentation was much more important. But why we are having this webinar today is probably the reason is this. The autoantibodies, which have come up in a big way in myositis, which have actually changed the outlook of the disease. How all myositis, which were put in the same basket, how they had turned out to be very different. Actually, I'll not be speaking much about it, which is the domain of Dr. Monika. I'll only be giving a brief as to how we use them in identifying diseases. So if you see this complex picture, I'll try to make it simpler. So let's see this one group which has got anti-cytoplasmic antibodies as well as anti-nuclear antibodies as far as Hep2 cell line is concerned. These two antibodies broadly classify myositis into 2 groups. One is called anti-synthetase syndrome, as I just told, and then we have the overlap syndrome, right? Then We have got two major features in this group, that CTD overlap is found in the anti-nuclear antibody positive, this group of myositis, and lung disease is quite common in the anti-synthetase part of group of this diseases. Then we have got this another big second group, which has very common skin disease, which has prominent calcinosis in some of them, and which may also have malignancy. Now, here, as I told, there are two major features, skin disease and malignancy. The fourth group and the third group are relatively smaller one. The third group is called inclusion body myositis, where antibodies are being described, but nothing has come off as of now in the commercial kits. And then we have got a smaller group, another smaller group called necrotizing myopathies, where we have two different other antibodies, and the features are severe myopathy and dysphagia. This is how this has been divided. But once we come to clinical studies, trials, or experience, actually everything is based on these three major groups. This anti-synthetase and CTD overlaps. Then we have got this group of dermatomyositis, and then we have got inclusion body myositis. The necrotizing myopathy is not very common. Yes, they are common as compared to inclusion body myositis, which is not very commonly seen. However, the studies, if you see, they are basically made up of basically based on these three groups of diseases. So clinical prevalence, you have this group of diseases, and necrotizing myopathies as the commoner ones in the OPDs. Now, how common are they? So epidemiology says that their prevalence is around 2 to 6 per 1 lakh population per year. Now, they mainly involve 6 major systems, and these are mainly musculoskeletal system. Then we have peripheral vascular system, pulmonary system, cardiovascular, GI, and obviously dermatological system. The mortality among these diseases, as I told, that are groups that are the studies which are based on is dermatomyositis, polymyositis, and inclusion body myositis. Mortality is highest in dermatomyositis group as compared to polymyositis, and lowest in inclusion body myositis. If the mortality happens, that happens to be highest during the first year. However, with the present treatment, 10-year survival is good. Now, if we look at the causes of mortality in these patients, these are mainly lung disease. That is why the management is very important according to what the patient has. Is it just the musculoskeletal and skin involvement, or patient also has lung disease? Then second is malignancy, and third is cardiovascular disease, which happens not more commonly because of the disease, but because of the treatment that we institute. Now we look at the pathogenesis in brief. Like any other autoimmune disease, there are certain genetically susceptibility features, and in combination with some favorable environmental factors, the immune system gets dysregulated. And once we look at that, the humoral as well as the cytotoxic arms both are activated with prominent involvement of interferon alpha. This interferon alpha signature is very important, which is like lupus or like scleroderma, and that is why it has been thought that the antibodies or which are against TNF, which are against interferon alpha, may be useful in the treatment. However, nothing as of now has come to the commercial use. Other medications which are based on other pathways in this immune system, like rituximab, like belimumab, uh, like your abatacept, these have been found to be useful, and I'll come to that in some time. We'll describe the 6 groups one by one and try to see what their features are. So dermatomyositis is classically the biggest subtype of this group, and it has classically muscle and skin involvement. However, there can be sometimes when the muscle involvement is seen in only on biochemical evidence, like the patient doesn't complain, but once you do the test, you find CPK is elevated, when it is called hypomyopathic dermatomyositis, and it could be completely amyopathic when the muscle involvement is not there. Together, these are known as clinically amyopathic dermatomyositis once the duration is 6 months or more. Now, myositis, when it is histologically proven without any skin involvement, then we call it dermatomyositis, sign dermatitis, right? Now, this also has been further divided into 6 groups based on what kind of antibody the patient has. And this is important because their clinical features and management would differ. So these 6 antibodies which are seen in dermatomyositis are important. Anti-Me2, anti-MDF5, TIF1, NXP2, and SAE. Now they have got different features, which I'm coming to in future slides. So first of all, the first type, the classical type that we have heard of, seen in our OPDs, which has got a rash on the forehead, heliotrope rash is there. We have got the shawl sign. Sorry. We have a shawl sign, V sign, myositis is there, Gottron sign, and papula is there. This is a classical dermatomyositis, and it is usually seen in Me2 positive dermatomyositis. Let's see the next type, where we have all those classical features as I've highlighted in yellow, but they have also very prominent calcinosis, and they have got increased risk of malignancy. So this is the one which is seen in NXP2 positive patients, right? The third one is another which has got again prominent features of rapidly progressive interstitial lung disease. Apart from the classic rash of myositis, it has got skin ulcers, prominent skin ulcers, and polyarthritis. Now this type is MDF5 among the dermatomyositis. The next one has got very high risk of malignancy. It's not just the risk of malignancy that we just saw in NSP2. This is TIF1 gamma positive myositis, where you have got, apart from the rash, you have got prominent dysphagia and skin rashes, which are not very classical of dermatomyositis, like blistering and necrosis. And then the last subtype which we have is SAE, where again you have increased risk of malignancy, but here myositis is not a very prominent feature, or even if it develops in later age. Yes, Asian patients are seen with interstitial lung disease, and these patients can also have dysphagia. Now, this is a classical patient with classical rash of dermatomyositis, which is the garden variety Me2 positive. You can see this shawl sign, V sign. You have this heliotrope rash mainly on the upper eyelids, and you also have this periorbital erythema. The skin on the forehead is also prominent and red, looks edematous. So this is the classical Me2 positive dermatomyositis. We'll come to other clinical pictures also, but first I'll just describe the groups. Anti-synthetase syndrome. This is a relatively homogeneous group within inflammatory myositis. All these patients in this group have an antibody to one of the amino acid tRNA synthetase antibody, which is now at least 12, I think 8 antibodies have been described. Myositis is not very consistent feature. In this particular group, you have ILD as the most consistent feature. And if you have an antibody to anti-PL7 and PN12, you have worse prognosis. You can see that interstitial lung disease, arthritis, Mechanic's hands is another classical feature here. And you have prominent Raynaud's phenomena. That should be thought of once we have a patient of all these features. Anti-synthetase syndrome should always be thought of. And then the next one is immune-mediated necrotizing myositis. Severe proximal myopathy with very high CPK, which runs in thousands. And the patients here will complain of very prominent muscle weakness, but they will also have cardiac involvement, especially in anti-SRP positive myositis, and also very prominent dysphagia. But what are the other things that you should see here? That histopathology will show us necrosis with regeneration of fibers, but there will be very little inflammatory infiltrate. Systemic manifestations are rarely prominent. They don't have much of arthritis, rash, ILD. And again, it is a heterogeneous group because we have got 2 subclasses based on whether they are anti-HMG-CR positive or anti-SRP, or they are negative. Severity is always very high for anti-SRP as compared to anti-HMG-CR. However, extramuscular manifestations, if we see, seronegative variety will have more of extramuscular manifestation. As such, they are rare, but even if they happen, they will happen more in seronegative variety. And the last type that we have is inclusion body myositis. Usually happens in older age, 50 years. They will have history of falls because it not just involves the proximal muscles, it also involves the distal muscle. And the prominent feature here would be atrophy of the muscles of flexor groups of muscles in upper limbs as well as in the lower limbs. Extramuscular features are very rare. It's a slow growing chronic disease. Patient will have a disease course which will last over decades. Dysphagia is prominent in this disease, and response is very poor to therapy. But this is very rare. It is hardly ever seen. Polymyositis is again become non-existent entity nowadays, because it is said that whatever we always thought of polymyositis, actually all those were antibody positive antisynthetase syndrome or other varieties which we did not know at that time. So they were misclassified as polymyositis. We don't see this variety nowadays. And then overlap myositis is then myositis happens in association with other connective tissue diseases like lupus, like scleroderma. Here you have antibodies present which are like anti-Rho, U1RNP, La, the other antibodies which are not very classical for myositis. And we have prominent extramuscular features because these are overlap myositis. Skin involvement if we see, because we have already discussed the myositis. What is the skin involvement? I have told you all this sign. Now I'll just show you some pictures. Can anybody tell what is this and what is this? So these, if you see, there are fleshy nodules, fleshy papules over the MCPs and PIP. So these are called papules, the Gauthron's papules. And if you see here, these are macules. These are not raised, but they are again at the joints. These are called Gauthron's sign. Similarly, you see these fleshy papules, and these are not raised, but these are erythematous. These are Gauthron's sign. Heliotrope rash, which is seen classically in dermatomyositis like Me2 positive or NXP2, that is there. You have in the beginning stage, when the muscles are edematous, skin is edematous, you can see this kind of periorbital puffiness, the classical V sign, shawl sign on the back, and you can see these cracks and hyperkeratotic lesions on the skin. These are actually the mechanic sands, and these mechanic sands will disappear if you treat the patient with steroids. Prominent calcinosis in NXP2, you have prominent skin ulceration. These are features of MDA5 syndrome. Now, MDA5 is one variety which has to be remembered because it has got a very significant and very florid interstitial lung disease that can just kill the patient very fast. So MDA5 can be identified once you are sitting in the OPD. Usually it will have skin ulcerations, which are very prominent and not seen in other varieties. Usually it will have symmetrical involvement. You can see ulcerations which are almost symmetrically involving the digits. You can see these here. Again, another patient, you can see on the elbow, on the shoulder, prominent skin ulcers which are literally symmetrical. These should always raise the suspicion that this patient has got MDA5 antibody positive, and that is why you should order for these antibodies, which Dr. Monika would discuss. Now, pulmonary involvement can happen in almost 80% of patients with myositis, and mostly in antisynthetase syndrome and anti-MDA5. Usual patterns are NSIP, and they have a favorable prognosis, respond very well to treatment, if you don't have MDA5. Once you have MDA5, watch for rapidly progressive ILD causing ARDS and requiring ventilation. Otherwise, ILD course, except for MDA5, is chronic, subacute to chronic, and it is sometimes asymptomatic also, but it responds very favorably to the treatment. In other patients who do not have MDA5 but have ILD, what are the signs that these patients may also develop ARDS? Once you have a combination of organizing pneumonia and NSIP, you should always watch for these patients. They are the ones who will develop ARDS in spite of not having MDA5. Now, how do we diagnose these patients? So now we have this recent classification criteria which is available, which takes into account the age of onset, muscle weakness, skin manifestations, other clinical manifestations like dysphagia, as I told. And for the first time, autoantibodies have come into the picture, which again, Dr. Monika would speak, along with muscle biopsy features. Depending upon whether the patient has muscle biopsy or not, you can score all these features, and based on that, we classify the patient to have a possible, probable, or no myositis. So if you have if you have a score of 5.5 without biopsy or 6.7 without biopsy, the patient may have probable myositis. Definite is when the scores are 7.5 and 8.7. And if the patient has a score which is less than, actually it is 5.3. If it is 5.3 and 6.5, the patient definitely does not have myositis, and it is important because mild CPK rise can be seen with viral myositis, hypothyroidism, and other disease. So we should always know that. Now, guidelines for autoantibody testing in malignancy. Should we test for antibodies on all the patients? Yes. And should their titers be monitored? No. Detail, Dr. Monika would discuss. When should we do cancer screening and how much cancer screening should we do? Should we subject every patient? So the guidelines that are available from the UK in the Rheumatology Journal, they say that if the patient has got older age at onset, male gender, appearance of dysphagia, cutaneous necrosis, resistant to usual therapy, rapid disease onset and progress, TIF1 gamma and anti-NXP2 antibodies, and a patient who is negative for any myositis specific antibody. These are the ones in who you should do a cancer screening within first year of onset. How much should be done? You should not subject every patient to PET CT. What they say is that good clinical examination and a PET CT, sorry, a CT scan which involves the pelvis, abdomen, and thorax should be enough. Now, management-wise, the management is same like we do in other rheumatic diseases. We start with steroids. Here we give almost 1 milligram per kilogram steroids. Pulses may be required if the patient has got impending respiratory failure, neck flap. Otherwise, we start with usually methotrexate and azathioprine. If the patient has got poor prognostic factors, then we can think on adding IVIG or rituximab right from the beginning. Otherwise, we choose second line therapy as MMF, tacrolimus, and cyclosporin, and third line as rituximab and cyclophosphamide. However, certain older papers give this very vague chart, which is sometimes clinically very useful. So I'll tell you that all these disease manifestations have a very good response, like muscular. The muscles respond very well to almost all the drugs. Skin is also good enough, but sometimes azathioprine, cyclosporin, and tacrolimus, it doesn't respond. And other manifestations are also responsive to some of the drugs. But you can see that rituximab is good across all. And if you have Me2 or SRP positive, SRP was one of the most severe necrotizing myopathy, you should upfront give rituximab. However, this is from an older paper. All the things are not very established nowadays. Like if you see, it says that if your patient has got ILD, you should watch for the side effects of methotrexate, which is not true. Patient having ILD is not a contraindication for giving methotrexate. Please remember that. And then if you have an ILD, how should you treat? If you have only mild to moderate disease, the patient has got mild to moderate disease, steroids with intravenous glucocorticoids, steroids or intravenous glucocorticoids with maintenance on either mycophenolate or tacrolimus cyclosporin may be enough. But if the patient has got severe disease, more of lung involvement is there, more than 50% of lung is involved, you should start the patient upfront on rituximab and cyclophosphamide. If the patient still does not respond, we can go ahead with abatacept. This is how it is followed. And thank you very much. I'll be happy to take the questions in the end.
Thank you so much, Dr. Ranjan. And I would again invite Dr. Monika Agrawal to take the diagnostic section of the autoimmunity forward. So maybe Dr. Monika Agrawal, if you can share your screen and
Is it visible?
Yeah, visible, ma'am.
absolutely.
Okay. Thank you so much, Dr. Ranjan. You have helped me out to actually explain what are the different kind of antibodies. Our listeners will be, I think they will be now understood. There are various types of autoantibodies. Now they are very much important nowadays in the diagnosis of various autoimmune disorders. Not only the idiopathic inflammatory myopathies, but the other connective tissue disorders also. There is one slide I always share in my webinars or in my CMEs. That is, there are certain terms, common terms we are using in diagnostic test. That is, what is it ANA or it is ACA? Means there is an anti-nuclear antibody or anti-cellular antibodies. Usually, the terminology we usually use is anti-cellular antibodies, anti-nuclear because nowadays there are many of the antibodies which are present in the cytoplasm, not confined to the nucleus. So the another terminology, it is ANA or ENA. Usually the term extractable nuclear antigen are being used, although these antibodies against the antigens are specific, but these extractable antigens are not only confined to nuclear. they are also present in the cytoplasm. So these misnomers are there, but still they are in the continuation. Most of the doctors are using these words. Otherwise, this is basically the anticellular antibodies, and these are the extractable antigens against which we are detecting the antibodies. And when we test for the ENA antibodies, only when the titer is more than ANA titer is more than 1:160, to some extent we can say yes, the patient may have autoimmune disorder, but the positive not always says the patient is with an autoimmune disorder, and the negative doesn't rule out the presence of autoimmunity or autoimmune disease. So these are the most common extractable antibodies we detect in most of the connective tissue disorders. Now we come to the journal terminologies. What are myopathies? These are basically the muscular disorders. What is myositis? These are basically the inflammation of muscle tissue. And there is certain times the people use fibromyalgia word with myositis. So there is a basic difference that myositis is usually present with the weakness of muscle with pain, and fibromyalgia, there is a pain and tenderness, but there is no weakness of the muscle. Most of the things Dr. Ranjan has covered, what are the different types and what are the basic causes which are triggering the presence of idiopathic inflammatory myopathies in most of the patients. They are from hereditary to the infections, the toxins, and the immune response. If we talk about nowadays, among the infectious causes, the viruses are playing a very important role in that. The Coxsackie virus, the enterovirus, nowadays post-COVID, the COVID virus is nowadays post-COVID, there is an increase of the cases of myopathies. There are certain bacteria also, there are fungal causes also which are causing basically the myositis. The 6 types of myositis already Dr. Ranjan has talked about. There is one drug which is commonly used by the patient are the statins. These statins are main cause of basically the myopathies in the person who are taking statins. And these symptoms usually once the person stops statins, the recovery occurs within 3 to 6 months. But statins, there are other drugs also which causes myopathies. There are certain when we talk about the pathophysiology, that is also covered by Dr. Ranjan. But I just want to tell, when we are going to talk about the histopathology section, the histopathology part, the polymyositis, and polymyositis mainly the infiltration of CD8 cells and macrophages and the endomysial layer of the skeletal muscles affected. And when we talk about dermatomyositis cases, in which the perimysial layer of skeletal muscles are affected, and normally the infiltration of CD4 and B cell, means the humoral attack is more commonly seen in dermatomyositis in comparison to the polymyositis cases. Most of the DM cases, as already Dr. Ranjan said, that the carcinoma either present at the time of the diagnosis or later on may patient develop with the cancer. So when we talk about the various diagnostics tests, because most of the patient may present with the neck pain. So are you sure that it is just a neck pain? How to go with the diagnosis of these cases? If the patient is present with the pain, weaknesses in the muscles, so how we should proceed for these? There are certain guidelines that is by the European League for Against Rheumatism and American College of Rheumatism. These are the criteria. In 2017, they have given for idiopathic inflammatory myopathies. There is a criteria that Dr. Ranjan has showed, in which the clinical, laboratory, and the diagnostic criteria are there with or without muscle biopsy. So the clinical symptoms also, as already told about Dr. Ranjan, that is the Cotron sign, the heliopter rash, heliopter sign is there, the Cotron rashes, papules are there. So these are the clinical symptoms which are basically included in this criteria. When we talk about the laboratory diagnosis, there are hematological diagnosis, there is a serological diagnosis, there is a detection of specific autoantibodies, and the histopathology. Histopathology is basically covering the muscle biopsy and the skin biopsies. Other than that, there are certain other diagnostic modalities that has to be used in the diagnosis of IIM. That is the radiologically, the myography, nerve conduction studies. There are pulmonary function tests, and not the least, but the cancer evaluation, because most of the dermatomyositis cases are basically present with the cancer, or later on they may present with the some carcinoma. So when we talk about hematological investigations, most common is the complete blood examination. There is an increase in lymphocyte count can be seen. ESR may be normal, be slightly increased. These are basically not involved in 2017 guidelines or the 2017 criteria, but normal patient, you can go for these tests in these patients. But the criteria which involve basically the diagnostic test are the creatinine kinase, lactate dehydrogenase, SGOT, and SGPT. The creatinine kinase, because of the involvement of skeletal muscle in these patients, there is a chances of increase up to 50 times of the normal, and this creatinine kinase may help in the monitoring also in the treatment monitoring also in these patients. Other than that, CRP can also be included, which can be increased, or maybe the patient present with the normal CRP levels. When we talk about the histopathology section, as I already told you, in polymyositis cases, mostly the patients are present with the endomycelial infiltration of the mononuclear cells. But in cases of dermatomyositis, there is a perivascular involvement of infiltration of the mononuclear cells. Other than that, according to the 2017 criteria, the criteria also include there is a perifascicular atrophy or there is a rimmed vacuoles. If they are present in a skeletal muscle biopsy, then it also helpful in the diagnosis or defining that the patient is a case of idiopathic inflammatory myositis. It will help out in that. Now, the most important part, the when we talk about various types of autoantibodies, which are usually important in the diagnosis of myositis cases, idiopathic inflammatory. If we talk about ANA, how ANA or ACA by IFA is useful in that, although in my practical experience, they do not help much in the diagnosis, direct diagnosis of IMM. Lekin yes, if there are the patients who are present with the overlap syndromes, in those cases, it definitely work out very well, because in those cases, we will be able to diagnose the other causes of the other simultaneously present rheumatic diseases. In such cases, definitely the ANA diagnosis by IFA is very, very much helpful. But when we talk about antibodies, which are very helpful in the diagnosis of IIM, there are two modalities are available. The most common modality is only the blot. Most of the antibodies, the autoantibodies which are present for the diagnosis of IIM are on the blot. Only one or two antibodies ELISA is available. So main diagnosis of the antibodies are basically on the blot. There are two types of autoantibodies. First is the myositis associated antibody, and second is the myositis specific antibodies. So the myositis associated means these are not disease specific, because these are not, if these antibodies are present, we cannot rule out that the patient is only have a myositis. The patient may be present with some other connective tissue disorders. They are usually seen in overlap syndrome, such as KU, means they are usually these antibodies are mainly present with the overlap syndrome along with systemic sclerosis or with Sjogren's or with SLE cases. Same with the PMSCL 100 or 75. In these cases, if these antibodies are detected, they are normally present overlap syndrome with the systemic sclerosis. Then anti-RO antibodies. If they are present with Jo1 antibodies, that is mainly in the anti-synthetase syndrome, if they are present, they present with the very poor prognosis, because the patient may present with the severe ILD. In these cases, there are SSB antibodies can also present, and with the mixed connective tissue disorders, there is a possibility the patient may present with the myositis also. So these are basically the overlap. These myositis associated are usually present with the overlap syndrome. In such cases, definitely ANA by IFA is very, very useful, along with the followed by the blot or the ELISA, which mainly detects the antibodies specific to those rheumatic diseases. Now, second antibodies are the myositis specific antibodies, which have a very, very important role in determining the prognostic value, as well as we can easily predict the disease course. So they helpful for us to find out the risk of development of cancer or the interstitial lung disease, that's it, ILD. So I have divided in the antibodies which are usually present in different inflammatory myopathies. First, the antibodies which are specific for For dermatomyositis, basically the Mi2, they have two isoforms, that is Mi2 alpha and Mi2 beta. So this Mi2 beta is commonly associated with the carcinomas of breast and cancer. Then there is a TIF1G, this is basically the transcriptional intermediary factor 1 gamma antibodies. And again, these antibodies have a carcinoma association, that is basically the pancreatic carcinoma. And these antibodies, if they are present, they are mainly giving the idea that patient may have a hypomyopathic dermatomyositis. Then there is an SAE antibodies. Definitely the patient may present with the dysphagia, and the patient may have a dermatomyositis with ILD. Then the antibody which is very, very specific for amyopathic dermatomyositis is MDA5. This is basically a melanoma differentiation associated gene 5 antibody. This is very highly specific for amyopathic. But the thing is that if the person has an MDA5 antibodies detected, the chances of progression towards ILD is very high. Today only we have a myositis panel, and just half an hour back I have discovered one patient of a myositis with MDA5, and I have discussed the case with the clinician, and the patient is presented with ILD symptoms, and the prognosis, definitely the ultimately the clinician is going to take a call on that basis. The antibodies which are specific for juvenile polymyositis or dermatomyositis is NXP2 or MJ. In my autoimmunity, as I am seeing in IFA, most of the time we have seen that there are this NXP2 antibodies in ANA typically present with the nuclear dots, multiple nuclear dots. But these multiple nuclear dots, most of the time is significant along with AC21, that is the cytoplasmic pattern for AMA2, which mainly directing towards PBC. But if the patient is present with dermatomyositis, juvenile patient is present with polymyositis or dermatomyositis, these multiple dots, if the PBC is not there, then definitely is directing towards the presence of NXP2 antibodies. So in such cases, the myositis panel must be checked for the presence of these antibodies. If any IFA pattern, if you are seeing multiple nuclear dots but without any AC21 and without any liver involvement, it is the most important thing is if the patient is present with this NXP2, the calcinosis cutis is common in these patients, and if this antibody is commonly present in juvenile cases, but if they are present in adult, they are associated with the different type of carcinoma. The other antibody which is commonly seen in immune-mediated necrotizing myopathy, that is called the anti-SRP syndrome, is the SRP antibodies, that is signal recognition particles. In 5% of the polymyositis cases, you have to see that all these myositis-specific antibodies have a specificity from 95 to 100%. So sensitivity, although sensitivity is poor in maximum of 25 to 30% in most of the antibodies, but once they are present, they give the probability, they give the specificity of 100% in most of the idiopathic inflammatory myopathies. SRP along with HMCGR antibodies, they basically the marker of this disease not only, but they shows the involvement of heart muscles as well as the esophageal involvement. This HMCGR antibodies frequently seen in patients also who are taking statins. So there is if the progression, if we'll say the ILD is also there, but it is of a less severe type. But yes, as far as SRP antibodies detection are resistant to the treatment, and CPK levels are very high because it is necrotizing. The antibodies which are specific for anti-synthetase antibody, Dr. Ranjan has given more antibodies. I have focused only the specific antibodies which we are able to detect in our blood. That is the Jo1 antibodies, which is the histidyl transfer RNA synthetase antibody with the 100% specificity if it is present if it is present in the myositis blood. And Jo1 along with RO52 proceed for a very bad prognosis in such cases, specifically with the presence of ILD, and all the clinical part that are already covered by Dr. Ranjan. There is EJ, OJ, PL7, and PL12. All these antibodies are classically involved in antisynthetase syndrome. In these cases, the chances of ILD is also very high. Is there is a coexistence of two myositis specific antibodies, and is there any progression help? It mainly affects the progression of the disease. Yes, there are certain papers are on that, in which there is cases which have been reported that there are two myositis specific antibodies can be present, they can coexist, but the possibility is rare. And how they are clinically how they are impacting the clinical course of the disease, it is also not clearly understood. But yes, in some cases, it has been seen that they merely give the worst prognosis, but in some of the cases, they are not affecting at all. Because dermatomyositis cases are mainly present with the cancer evaluation, most of the cancers are there associated with them. So there should be an age and sex appropriate cancer screening must be done, which include colonoscopy. In case of females, pap smear should be done. In case of uterine cancers, if you want to detect breast cancer, the mammography is the best. The general test we can go is the routine blood test or routine biochemistry we can go for, and the urine analysis. The PET-CT can be done in all dermatomyositis cases in which there is a positivity with NXP2 antibodies as well as TIF1G antibodies, because the development of cancer within 3 years is very high with these two type of antibodies. And definitely, if the ovarian cancer is suspected, we can do the serial monitoring with CA125, and radiologically, the transvaginal ultrasonography can be done to check for the presence of ovarian cancer. There are most of the cases, there are various differential diagnostic things are there. There are multiple, but I have chose two because these two I have found that we can go for the basically for the laboratory investigations also, such as one is the hypothyroidism, in which you will be able to basically check the thyroid levels in the initial state, because in these cases muscle enzymes are also increased. Secondarily, the myasthenia gravis, because most of the patients may present, they have a day-to-day activity, they hampers day-to-day activities in myasthenia gravis patients also. But in this case, you are able to basically detect the acetylcholine receptor antibodies. The muscle enzymes are usually normal in these cases. And I have taken only these two basically because we will be able to diagnose these cases. So what are the takeaway message in by the diagnostic, if we talk about the diagnostic utility of all the tests we are doing in IIM is a rare disease, but the criteria we are using, EULAR ACR criteria, it is very helpful. On the clinical side, definitely, it will help you out to diagnose a case with the dermatomyositis. If the patient with DM without muscle involvement is there, you can go for the skin biopsy. And if the DM patient, there is no skin involvement, then you go for the muscle biopsy. ANA-IFA have a limited role, specifically in the overlap syndrome. Myositis specific antibodies, yes, they are definitely helpful in determining the prognostic and the disease course of the IIM. Histopathological examination, very important role in the diagnosis, because ultimately the criteria is based on that, with or without muscle biopsy. And as the dermatomyositis cases are mainly associated with the cancers, so cancer evaluation should be done, age and sex specific. Thank you so much. And before I concluding my talk, I just want to share that this basically webinar which we are doing here is the whole idea of this webinar is to create awareness among the clinicians, among the patients, what autoimmune disease all about, and how should we proceed, and how the diagnostic, what is the management approach should be there. For this, DrBLalLab Clinical Laboratories have initiated the Center of Excellence of Autoimmunity. There was a small story behind that. As I was working in for autoimmune disorder diagnosis for last last 15 years. So when I came to Rajasthan, I associated with Dr. B. Lal sir, I found that the people are not aware. They are just writing ANA, IFA, and other tests related to autoimmune. There was no clinical judgment of those cases. There are no clinical connect of those cases. So I suggest, sir, we should give a umbrella under one roof, so that we will be able to provide all diagnostic facilities, the clinician connect, as well as the research activities, along with the education, as well as the training schedules for these all autoimmune disorders, so that people should be aware about what are the problems they are facing, and how should they be diagnosed, and how should they will be managed if once they are diagnosed with autoimmune disorders. And we are basically enriching our clinicians also, ki what are the recent advances in all autoimmune disorders, so people may become aware of all these things under this Center of Excellence initiated by Dr. B. Lal Clinical Laboratory.
Meanwhile, we can take up some questions and answers that the
Yes.
chat has been sharing with us throughout the webinar. So I think there was a question from Dr. Gaurav Sisodia. He was asking a 40-year-old male pre-diabetic, obese, BMI 35, hypertension, complaining of shoulder pain and overhead movements like hair combing and muscles exam. Atrophy of deltoid muscles are non-tender. So I think this was the question by Dr. Gaurav. I think
Yeah.
if Dr. Ranjan would help
So,
us with,
yeah, so it's a 40-year-old male, BMI is 35,
yeah.
and diagnosing any kind of myositis at this stage when the patient has got only shoulder pain, that to doing overhead activity, we should be very cautious. It is unlikely to be myositis. I would rather be careful in labeling him of any kind of myositis. I will first do muscle enzymes, and I would like to follow some amount of muscle enzymes may be raised in him also, but I would like to see the trend after 1 to 2 months and see if they are rising. Otherwise, it is unlikely, highly unlikely to be a case of myositis.
Okay. So I hope Dr. Gaurav, if he's present in the session, he's got his answer. And there was an appreciation by Dr. Bhupendra Kumar Mandawat. Thanks to Dr. Ranjan for the valuable and informative presentation. He's a senior professor, Government Medical College, Kota.
Yeah, I know him. I know him.
Yeah.
Yes.
Then there was a question. I think this was answered by Dr. Gaurav Sisodia also. It was a question, क्या thyroxine medicine से hypothyroid या hypothyroidism में convert हो सकता है क्या? I think it was answered by Dr. Gaurav. Then
Yeah.
again, there was a question by Dharmendra. What is the risk of cancer for people with dermatomyositis? Apart from that, medical treatment, what other things can help in myositis?
So cancer risk is there, but like I also discussed and Dr. Monika has also told, we should be very cautious once you have one of those red flag signs. A male person developing at the older age who is TIF1 gamma positive, NSP2 positive, he is having SRP which is positive. These patients who have very furious rash, not responding to treatment, these are the signs when you should become alert. And all the screening actually has to be done within the first 3 years. That is the time when maximum patients will develop cancers. And apart from medical treatment, the most important treatment for myositis is physiotherapy. If the patient continues to take medicines but doesn't do muscle strengthening exercises, actually nothing is going to come out. So the very first day, the moment you write steroids, before that, the first thing on your prescription has to be physiotherapy. The patient has to be taught active muscle exercises, mainly of the proximal muscles. Otherwise, the whole treatment will be useless after 10 years of duration.
All right. Thank you, Dr. Ranjan. Again, there is a question. Is there any role of Zolgensma injection? Why is it so expensive?
So Zolgensma is actually for spinal muscular atrophy. It is not for myositis. Spinal muscular atrophy is basically a genetic disease where a particular gene is not there, so its product is not there. And by giving this injection, you are basically replacing that. So Zolgensma is useful in SMA, spinal muscular atrophy, but it is not useful in any of our patients of myositis. So it should not be used.
All right. So this marks the end of the questions. If there are any other questions, chat, you can drop your questions in the chat section below. And if they are not, then we can just conclude this session. So I think if there would be any more questions, we will be sending a feedback form to everyone. So maybe we can jot down these questions and we can get an answer from Dr. Ranjan and Dr. Monika then, and can revert back to you all. I would like to thank you, Dr. Ranjan and Dr. Monika, on the behalf of DrBLalClinicalLab, Clinical Lab, Center of Excellence Autoimmunity, for being here, for giving a beautiful and insightful session on myositis and on the day of World Myositis Day. I think we are also in the verge of kind of creating an awareness among the people, and again, kind of correlating the clinical and the diagnostic aspects both. So thank you so much, Dr. Ranjan, for being a part, and thank you, Dr. Monica, for being a part. If
Thank you
there are
so
any
much.
feedbacks, you can just share with us. Yeah.
Thank
Thank
you
you.
so much.
Thank
Thank
you
you
very
so
much.
much, Dr. Andrew. Thank you so
Thank
much.
you, ma'am. Thank you.
Thank you.